All right, last but not least, we're going to be talking about cutaneous squamous cell carcinoma. Not often talked about at oncology conferences, very, but very important, very common disease. And as a lot of our treatments that we were just talking about, immune checkpoint inhibitors, are coming into earlier treatment for cutaneous squamous cell, it's something that there's going to be. It's not just going to be a dermatologic disease, but medical oncology as well. Happy to have Dr. Keith LeBlanc. He's a Mohs surgeon at the Skin and Surgery Center and associate clinical professor, LSU Health Science Center. He did his undergraduate at University of Virginia, medical school at LSU, residency, Medical College of Georgia, and fellowship at Total Skin and Beauty Dermatology, Gary Mohim in Birmingham. And so he'll be giving his talk on cutaneous squamous cell and an overview. Thank you so much.
Good morning, everybody. Thanks for having me. So, a quick overview. We'll start with demographics, epidemiology, pathogenesis, and then really kind of segue into what Danny was talking about, where, I think the crux of this talk really is that when we're dermatology residents and we're taught about cutaneous squamous cell carcinoma, if you ask any resident, well, what percentage of those patients metastasize have problems where they either need to be upstaged or involve multidisciplinary care, and you're talking probably 2 to 5%. But the reality is that most of the clinical pathologic staging that we use is found to be a little bit lacking, and now we're starting to get some genetic assays and involve some of these checkpoint inhibitors in the care of these patients. And so we'll talk about those high-risk features and the clinical pathologic staging that exists, and again touch on genetic assays and then finally treatment. I don't have a disclosure slide, but I do want to bring up, I do speak for CASL, which is the genetic assay. There's not going to be anything that conflicts with this talk, but I'm on their speakers bureau. So, as many of you know, cutaneous squamous cell carcinoma is the second most common skin cancer in the United States behind basal cell carcinoma. There's now over about 1 million cases of this annually diagnosed in the United States. Again, local, regional, or metastatic disease, somewhere in that 2 to 5% range overall. But that still leads to about 4,000 to 8,000 deaths per year, which is twice the amount of deaths in the United States that amount from cutaneous invasive melanoma as well. So importantly, from a dermatology perspective, the 3-year cumulative risk of a subsequent squam after an index squam is about 10x, right? So it's about 18%. And some of the literature, it's almost as high as 60, 70%. But other reference, you're more likely to develop a secondary squam if you have had 2 or more. If you're older, greater than 70, if you're immunosuppressed, poor differentiation, or size greater than 2. And as you'll see, we're going to hit on a lot of common themes of what those high-risk features are, and I just referenced a good amount of them. Your risk of a subsequent squam after an index basal is increased, but it's not nearly as much, it's about 6%. And interestingly, cutaneous squamous cell carcinoma is the most common cutaneous cancer found in African Americans. So high-risk features overall, and these are demographic high-risk features, not necessarily high-risk features with the tumor itself. So Fitzpatrick type 1 or 2 skin, think leprechaun. Male more than female. UV exposures, typically cumulative chronic low-level exposures. Ionizing radiation, chemicals, HPV. Some of the proteins formed in HPV, particularly E6 and E7, inhibit certain genes that were associated with development of cutaneous squamous cell carcinoma. And then in the nail unit, HPV 16 and 18 are associated. Other risk factors: chronic ulcers, thermal burns, tobacco use, long-standing skin disease like discoid lupus, LP, lichen sclerosis. And then Marjolins ulcers, kind of its own little subtype. This is malignant transformation of a pre-existing cicatrix, either with or without chronic inflammation. It's most common in the plantar foot. Interestingly, the average time from injury to this cutaneous malignancy transformation is about 20 years. But it's very important that we understand that the risk of metastasis in those patients, albeit rare, they have a very high metastatic risk. Almost a third or more of those patients have metastasis at the time of diagnosis. So squamous cell carcinoma and immunosuppression, for those of us that see a lot of cutaneous squamous cell carcinoma patients, this is something that we have to tread very, very lightly because these people have a 1 to 200 times increase in development of cutaneous squams, particularly depending upon the dosing regimen and how long their duration of immunosuppressive therapy has been instituted. Sirolimus, which is an mTOR inhibitor, can lead to fewer skin cancers, but it's got its own set of problems. CLL, and then hematopoietic transplantation as well. And again, it has to do with the regimen that they're on and the duration of therapy. Some drugs associated with cutaneous squam: azathioprine, voriconazole, BRAF inhibitors, etanercept, smoothing inhibitors, and thiazide diuretics. So I'll touch briefly on pathogenesis. Like I said, UV damage, the most common thing that we find in cutaneous squamous is cyclobutane pyrimidine dimer, CC to TT for any fellows in the room. The burden of mutations does lead to a complex pathogenesis, but P53 is the most common mutation, but also Notch mutations and RAS mutations are involved. So we talked about demographic high-risk features in the patients. In this case, we're going to talk about high-risk features of the tumor itself, right? So when we see patients, what do we look for in these cutaneous squams that maybe we need to either upstage the care of this patient or get multidisciplinary care involved? So increased tumor size, the threshold that I want you to take away from here is 2 centimeters. In one of the clinical pathologic staging, 4 is another one, but 2 is really the big threshold that we like to think about as dermatologists, Mohs surgeons. Diameter is the high-risk factor that's actually most highly correlated with disease-specific death. It's got a risk of recurrence of 2x, a risk of metastasis of 3x. Anatomic location can factor in, specifically the ear, lip, genitalia, hands, and feet. Poor differentiation, again, a risk of recurrence of 2x and a risk of mets of 3. Lymphovascular involvement, perineural involvement, which we see quite frequently. The average depth of involved perineural involvement is about 2.7 millimeters. Clinical PNI, where your patient is presenting with either neuralgia or pain in association with the tumor, has an overall risk of death of disease of almost a third. And then increased depth of invasion. Most references will say greater than 4 millimeters. As somebody who looks at skin all day, I actually don't have a micrometer on my eyepiece. I know there's another Mohs surgeon here. Jeff, do you have a micrometer on your eyepiece? If you need it. Do you ever actually do? I mean, so I see I need to get one. When I get down through the dermis and I'm in a deep sub-Q fat, I'm kind of checking that box, right? I'm going to respect, I'm not sitting there parsing out like, oh, it's 3.7 millimeters deep. I think they're fine. If I get down in a deep subcutis, I tend to tread lightly with those tumors. This is the second most common with disease-specific death, again, behind diameter. But this increases the risk of both local recurrence and metastasis by 10x. So this is the highest among all the risk factors where we're worried about local recurrence and metastasis in these patients when they have an increased depth of invasion. Immunocompromised, we've already touched upon that, but it is important to note the hazard ratio for recurrence of a cutaneous squam after definitive treatment like Mohs in an immunocompromised patient is like 4 times. Recurrence in general, tumors arising in a burn or a scar, which we've already touched on, and then histologic high-risk features that you'll sometimes get on a path report like sclerosing, basosquamous, small singular clear cell, spindle cell, pagetoid, or poorly differentiated. All right, so why do we stage these patients? So again, we have a large number of these patients that we see. I would bet, I don't run the numbers, but I probably see a couple hundred cutaneous squams a year easily. And the majority of these people have excellent prognoses, right? So what are we staging them for? Well, we're staging them because, as we already talked about the death numbers, that it's dwarfing cutaneous melanoma, but there is a small subset of these patients that have poor outcomes, unfortunately. Most of these deaths are actually due to unresectable locoregional disease and not distant metastasis, so important locoregional control. Established locoregional control is extremely important. And again, the goal is to identify those a subset that are at risk for unresectable local disease and metastasis. So I'll touch on the 3 main clinical pathologic staging, and I'll start with AJCC. So kind of a busy slide, but the important takeaways here are I talked to you guys about the tumor and 2 centimeters being an important threshold. So basically you go from T1 to T2 with a tumor that's greater than 2 but less than 4 with AJCC and has no other associated risk factors. And the reason I say no other associated risk factors, if you're greater than 4 centimeters, if you have perineural invasion, you have deep invasion, or you have minor bone erosion, then you're automatically a T3, okay? Where are we here? So yeah, the threshold greater than 2 but no other risk factors, you're a T2. Any of those risk factors, you're a T3. I would like to point out, it is a little bit interesting here, that poor differentiation, immunocompromise are not associated as high risk factors per AJCC. And then the other thing, and I don't have it bolded, is that AJCC staging is technically limited to cutaneous squamous cell carcinoma, the head and neck only. Most of what I see is head and neck as a Mohs surgeon, but I certainly see difficult to deal with cutaneous squamous cell carcinomas on limbs and trunks occasionally as well. From an N staging with AJCC, basically if you have, If you have no involvement, you're an N0. If you have metastasis in isolated ipsilateral nodes and you're extra nodal extension negative and you're less than 3 centimeters in diameter, you're an N1. If you break any of those thresholds, if either you have extranodal extension or you're greater than 3, you're in that N2 or N3 category. And then finally, no distant Mets, M0, distant Mets, M1. So your stage grouping and the important kind of takeaways here. Number 1, if you are a T2, so again, you're greater than 2 centimeters, but you have no other risk factors, per AJCC, you are a stage group 2. If you're a T3, meaning you have either perineural involvement or deep invasion, again, not poor differentiation, so you're a T3 and you're N0, M0, you're a stage group 3. And if you have any nodal involvement, you automatically bump up to a stage group 3. So I already kind of touched on some of those with the animations there, but stage 1 to stage 2 is the T1 to T2 transition. Again, that 2 centimeter threshold with no other risk factors. T3, that being anything greater than 4 or any of the high risk factors, are always at least a stage 3. And then T4 is always a stage 4, irrespective of the nodal or metastatic status. Brigham and Women's, which, full disclosure here, this is what I use. Nothing against AJCC, and I'll talk about why I use Brigham and Women's, but it's a little bit easier for me to kind of keep in my head as I'm busy seeing patients, and I can kind of do this in my head a little bit easier than AJCC. So really, there are 4 risk factors to take home. Tumor diameter greater than 2. That's really the only one that's clinical. Everything else is histologic. Invasion beyond the subcutaneous fat. We already talked about that. Poor differentiation, which again is not touched on at all in AJCC. And then perineural invasion, particularly named nerves or a nerve diameter greater than 0.1. Okay. I don't know who came up with this, but the way that this works is you are a T1 if you have none of those. You are a T2A if you have one of those. You are a T2B if you have 2 or 3 of those. And you're a T3 if you have 4 of those. Okay? Again, most of the patients that I'll see where I'm thinking about upstaging these patients, whether that's serial imaging, adjuvant radiation, things of that nature, are in the T2A, T2B category. And the reason that I say that, if they've got all 4 risk factors, I'm upstaging that patient anyway based upon the percentages of nodal metastasis and disease-specific death that you see in these patients, right? And then the final clinical pathologic staging, which again, I really just want to point out the differences. And it's funny, Dr. Pershing, most of your slides had NCCN stuff. So from a derm perspective, nothing against NCCN, but this is one where I'd have to kind of have it behind the computer and reference it. But I do know the differences, right? So the differences here that stick out to me, because it's probably the most thorough of all of them, if I'm being honest. But the differences to me are every head and neck, hands, feet, pretibial, anogenital. So that, as a Mohs surgeon, we have what's called AUC, or appropriate use criteria. That is area H. So basically, if you have a skin cancer in these areas, they end up in a Mohs surgeon's hands, or very well should, based on anatomic location alone. I personally don't think if every single cutaneous squam on the face that I saw was a high-risk tumor, I think I'd probably be overstaging patients. I don't... But this is also the only one of the clinical pathologic staging modalities that reference immunosuppression, which we know to be extremely important as someone who cares for these patients. And then the other thing I do want to point out is most of what you see in Brigham and Women's is all in that very high risk category, right? So most of those check boxes with Brigham and Women's, the 4, so poor differentiation, deep invasion, and perineural involvement. Perineural involvement, if you look, actually is a high risk. It's right to the left there. It's high risk. And then if you have a named nerve or 0.1, which again is that threshold for Brigham and Women, they're a very high risk patient, right? So most of your risk factors associated with Brigham and Women automatically upstage this patient to a very high risk NCCN patient. Part of the reason that I use Brigham and Women's is, again, because it's a little bit easier for me to do on the fly, but there is some data to support that. So Emily Ruiz, a colleague who's a Mohs surgeon up at Penn State, did a study not too long ago where the Brigham and Women's staging was found to have a higher specificity and a higher positive predictive value. So I think it's just a better staging modality. And I think that this is in part because there's no poor differentiation being a factor in AJCC8, and that's extremely important, as well as this kind of homogeneity amongst the T2 and T3 classes with AJCC. So at least speaking for myself, how do we take care of these patients? So for Brigham and Women's stage 1 and stage 2, surgical therapy is the gold standard. I am a Mohs surgeon, so take that with a bit of a grain of salt, I guess. But you can consider radiotherapy for non-surgical candidates and topical modalities for in situ disease. And then at least for me, where the gene expression testing that we'll touch on here in a second comes into play is in that T2A, T2B category, right? So they've got one risk factor, they're poorly differentiated, and they show up in my office and their tumor is 1.7 centimeters. Okay, well, they're pretty close to that threshold of being a T2B. Or you have a T2B patient who really doesn't want to be upstaged or involve anybody else. Like, hey, I want you to go see this radiation oncologist or this surgical oncologist, and they're like, absolutely not. You're my doctor, and you cut it out, and I want to go home and watch Judge Judy. Those are patients that I'll try to push the genetic test on in an effort to really get them the care that their tumor may warrant based upon that genetic profile, right? For T2B or above, again, I have found myself as I evolve in my career, back in the old days with very little to no anecdotal evidence, when I had perineural invasion, it was like, well, we're just going to radiate that patient after the fact, right? Why? I don't really know. It decreases the likelihood of your recurrence, but I didn't have great data there. I find that now I do a lot more serial imaging. So it's funny, I think Dr. Pershing mentioned this as well. I'm in a private practice. I'm kind of out on an island. I'm not associated with a hospital. It's a little bit difficult for us when we get this multidisciplinary care. For me, these cutaneous squamous patients that are high risk are a great excuse for me to pick up the phone and call my surgical oncology and radiation oncology colleagues, which I certainly don't mind doing. But as this has evolved, I find myself more dealing with surgical oncology and more on the line of serial imaging and then radiating those patients when available or when appropriate. If lymph node involvement is confirmed, the next step is total imaging. If a lymph node is less than 3 centimeters, and we already referenced that with AJCC, you basically excise the affected node only. If localized but unresectable local regional nodes are found, treatments, radiation, and chemo. All right, so I've already touched a little bit on this gene expression profile testing. I'll dive a little bit deeper. So this 40 gene test from Castle was made available about 5 years ago now. Of those 40, I can tell you 6 are experimental. 34 are experimental and 6 are control genes. They put this neural network algorithm. This is the only way I can touch on AI. Everybody else has touched on AI. AI is everywhere all the time now. This is my touching on AI, is that one bullet point. And basically what you get is a report that classifies a patient as either a class 1A, a class 2A, or a class 2B. And in kind of ascending order, those are low, moderate, and high risk for nodal metastasis. I would like to point out for those of you guys that are familiar, Castle also has a test that's been around a bit longer for melanoma. One important differentiator is that the melanoma test, because it's been around a little bit longer and has evolved in what it reports out, gives you not only nodal metastasis, but also the likelihood of recurrence. Up until literally like hot off the press, I have yet to see a Castle Squame test that gives us a report on recurrence, but I can tell you it's coming like within the next week or so. Like the next one of these I order, I'll probably get a risk of recurrence. But up to this point, it's only been 3-year risk of nodal metastasis. So which tumors do we test? And I've already touched on this somewhat, where at least speaking for myself, I'm in that Brigham and Women's T2A, T2B category, or T2A, T2B category, yes. These are kind of the boxes you can check for Castle in order to kind of validate your rationale for ordering the test, and it's all the high-risk features that we've already talked about, right? So tumor size greater than 2, anatomic location, immunosuppression, tumors that grow rapidly or with poorly defined borders, site of prior radiation or neurologic symptoms, and then all of those on the right-hand side, you're talking about a lot of those high-risk factors that we've touched on as well. So perineural involvement, poor differentiation, depth beyond sub-Q fat, or an aggressive histologic subtype. I've already talked a little bit about this, again, where you get the results are broken into 3, so a class 1, and the reason I included this slide is, well, what does that mean, right? So a class 1 patient where the GEP profile is coming back as low risk has an overall risk of metastasis of about 6.6%. My personal threshold for where I like to upstage those patients is somewhere in the 15 to 20%. Right? If I've got a 15 to 20% risk of metastasis, that's a patient where I'm going to get surg-onc and or rad-onc involved. So for me, my class 1s kind of stay with me and go back to their dermatologist and move along. The class 2A and the class 2B are the patients that, again, we get that multidisciplinary care started. And that basically just says exactly what this slide says, which is, so for a class 1A, you kind of leave it alone. For a 2A or a 2B, you talk about either nodal evaluation, adjuvant radiation, or some combination therein. So overall treatment of these cutaneous squamous patients, again, surgical treatment actually is a good option for a lot of patients if they are not AUC appropriate, and I already touched on that. When I go through that with patients, essentially breaking something complicated down, because I think there's like 80 check boxes in the AUC, how they calculate the score. It's really the anatomy, where you're located, the size of the tumor, and the tumor type, right? But for just a small, limb-associated cutaneous squame that's otherwise non-complicated, a 4 to 6 millimeter margin is adequate in a lot of those patients, right? Mohs surgery, and again, take this with a grain of salt because I'm a Mohs surgeon and that's all I do all day, but it's the gold standard if the AUC criteria are met. We've talked about a lot of those aggressive histologic characteristics at this point. The 5-year cure rate for primary cutaneous squame in the hands of a Mohs surgeon is about 97%, and with a recurrent tumor, it's about 90%, which is better than anything else out there. Radiotherapy is great for non-surgical candidates, patients who have surgical fatigue, elderly patients who are not likely to tolerate large surgeries, things of that nature. You fractionate typically in the 3.5 gray 3 to 5 times a week for a total tumor dose of 50 to 80 gray. The 5-year cure rate there is good, but it's not great. It's about 80%. Adverse events, although in the hands of a skilled radiation oncologist, you don't see a lot of these. Skin toxicity, alopecia, cartilage necrosis, pigmentary changes. You can get secondary malignancies. Again, speaking from the perspective of a Mohs surgeon, I really, really don't like to take care of tumors in areas that have been radiated because the tissue doesn't move and it's just extremely difficult to reconstruct those patients surgically. And then touching briefly on some things that have been touched on as well, right? So this is, admittedly, I'm like out of my scope here. I refer this out, and again, it's great. I call Danny. I'm like, hey. Yeah, right. So, I don't have SRT in my office. a lot of dermatologists and Mohs surgeons do. Not advocating for or against SRT, but yeah. So PD-1 inhibition, we've already touched on that, and people more skilled and experienced than me have already done that. But basically, in a tumor state, so there's PD-L1 on the tumor cell, it interacts with PD-1 on the T cell, and emits an inhibitory signal. So if you block this interaction, it prevents the tumor cell from evading the immune system. And we can see that here, right? So that leads to an upregulation of the immune response that Carly so expertly talked about. So what are those options, at least in cutaneous squamous? So you've got cemiplimab. It was approved in 2018. About a 50% response for unresectable locally advanced squam and about a 47% response in metastatic. And I'm not going to touch on adverse events because that's already been discussed. Pembro is another option and works similarly. Importantly, anti-PD-1 inhibitors cannot be used in organ transplant patients and similarly in folks with autoimmune diseases if they've been on immunosuppressive therapy within the last 5 years, which unfortunately from our perspective, those are high-risk patients with difficult tumors. But we do what we can. And then a final option would be cetuximab or Erbitux. This is an EGFR inhibitor, almost 70% disease controlled in advanced or unresectable squames. But I'd certainly like folks, again, who have more experience with that to talk about their experience in cutaneous squam, because this is one where I send the patient out, make sure that they get their referral, and oftentimes we don't get a lot of follow-up on those folks after the fact. And that's it. So I was quick, and I'm happy to take any questions.